Hi, everybody. Thank you so much for joining us tonight as we discuss a more rare group of the aortic community, cases of aortic disease in pregnancy and postpartum. And tonight we have two phenomenal doctors that are helping this community of women to navigate diagnosis and questions of reproductive health, family planning, and recovery, and basically any kind of questions that you can think of for this topic. So please welcome Dr. Rana Afifi and Dr. Melissa Russo tonight. You guys want to say hello? Give a little wave.
Hi, everyone.
So thank you guys so much for being here, because I know you guys are super busy, and I just want to tell everybody that these two women are incredible and always helping and giving so much of their time for the aortic community. And so we thank you and appreciate you more than you know. I just want you guys to be able to introduce yourselves really quick and just share your clinical expertise, your focuses, and any research projects that you have going on right now. So Rana, do you want to go ahead and get us started with that?
Sure. Yeah. So I'm Rana Afifi. I'm a vascular surgeon at UTHealth at UT Houston. I have a special interest in training in aortic diseases, aortic dissections, aneurysms, all of that. And through the years, I ended up focusing also a lot more of my research and interest in aortic disease in women, and specifically in pregnancy. I've created a group that's a multidisciplinary approach where we have multiple specialists together working and trying to manage women who have high-risk pregnancies because of cardiovascular diseases, including aortic diseases. And so a lot of the research and work that I'm trying to do right now is trying to understand more aortic disease in women and pregnancy specifically, and multiple projects, multiple approaches to it. Me and Melissa have collaborated on a few of those papers and manuscripts as well, and kind of like share our passion to this field. So Melissa, I'll let you talk a little bit about yourself.
Yeah. So I'm Melissa Russo. I am a high-risk obstetrician and also a clinical geneticist. I am currently in Rhode Island, in Providence, and I've been working in this community for a long time. And I do refer a lot of patients actually to Rana, and I help people all over the country. And so Rana and I have patients that we share, even though we're not in the same place anymore. And then my research, we're sort of in the process of finishing up analysis from a retrospective cohort that we did, mostly in people that have syndromic aortic dissections, like people with Marfan syndrome, Loeys-Dietz, vascular EDS, bicuspid aortic valves, and then people that have non-syndromic disease where they had like a dissection who had a pregnancy could also enter into this. And it was sort of just collecting reproductive outcomes retrospectively to try to get a deeper dive on some of the obstetric questions, and then trying to look at sort of long-term cardiovascular outcomes. In the future, I think what we're doing is just like Dr. Afifi, I'm involved in the broader field of sort of cardio-obstetrics, where we sort of take care of people that have congenital heart disease or any kind of cardiac disease in pregnancy. And there's a lot of collaborative stuff I'm involved in that is sort of going to be starting to collect prospective data on people, and a chunk of that is going to be aortic dissection, or people that have had aortic diseases at like 30 places all over the country. And so I think trying to sort of just continue to work really collaboratively with people is going to be the answer, just because these are such rare things that we're dealing with. So.
Yeah, and we appreciate all that research that you guys are doing. You know, there's, sorry, I'm getting a little feedback there. Well, a lot of people probably already know my story, but I dissected 22 hours after I delivered my second daughter. And at the time, I knew no one like me, no cases. And I really wanted to find other women that I could relate to and who understood me. And so I started this small support group of women to, sorry, I'm going to turn my volume down. It's giving me some feedback. Sorry about that, guys. Started this support group to have a place for women to connect with each other and ask questions and get comfort and encouragement, you know. And so these doctors here with us and others that they collaborate with as well are very useful to this community, because we get questions from all types of cases from these groups, whether somebody has an aneurysm, who's had a dissection, parents who have an aortic history, whose families, or, kids are starting families. And so we have all kinds of questions and referrals to the group, mostly based around family planning. And then, of course, ones who have just dissected, how to move forward. So there's going to be a lot of questions here that we have kind of written out, pre-written out questions that these patients themselves are asking all the time. So we appreciate y'all's expertise in answering those kinds of questions. But first, I just want to ask, just to get us started, what is it that, why does this happen in pregnancy? I don't know which of you would rather start to answer that question, but that's like the main thing going into this. When it happens, or if you're diagnosed with an aneurysm, why does this happen during pregnancy or postpartum?
Oh, I had to mute Melissa.
Oh, we're both muted, I guess. Yeah. Here you go, Melissa, yours.
Okay. So we don't know for sure, but the thought process is I think that there's some maybe underlying genetic change in people, whether you have a syndromic condition or a non-syndromic condition. And some people know their genetic changes and some don't. And what happens in pregnancy is normal physiology is that there's cardiovascular changes in pregnancy. And so things like your blood volume goes up, your heart's pumping faster, it's pumping harder. And all of this really creates more stress, I think, on the blood vessels in general. Additionally, your hormones change when you're pregnant. So your estrogen and your progesterone sort of go up and increase as you go through gestation. And the thought is that these normal changes potentially, I think, are making the blood vessels accommodate. But if there's something different about your blood vessels in general, this may be a time where there's more stress on the blood vessels. And so that's sort of the thought process of why this happens. And we know that the highest risk time is usually third trimester and postpartum period, but people can sort of have dissections at any point in the pregnancy.
Well, and along those lines then, so maybe Rana, you can answer this. There was a question can we truly prevent an event from happening? I mean, there are cases where people have had an echo and gotten diagnosed, or they know their family history, they have a multidisciplinary team kind of in play or involved, and they still may dissect. So can you, I guess, discuss that, or the importance of just knowing their family history and getting taken care of?
So I have an echo. Maybe you guys maybe can mute. I think maybe the ones that are not talking, we should mute, because I think we're hearing echo. Okay. Can you hear me better now? Good. So so I think it's the way right now to completely prevent it. There is nothing to completely prevent dissection. We can't really predict if it's completely not going to happen. So nothing that we guarantee, and this is a lot of how we start our conversations with a lot of our women who want to get pregnant, is that there is no guarantee. However, there are things that we can try that we know that can help and minimize, and that's the close follow-up, monitoring, maintaining the blood pressure under control, the medications and beta blockers that we still recommend during pregnancy. And some of the most important parts is as well, how do you plan the delivery around the pregnancy? And I think, just as Melissa mentioned, the highest risk is in the later part of the third trimester and in the postpartum period. So some of the things that we can do, and some of the things that we've done with women that get pregnant and they are at a higher risk, is try to not have them get to the full term. So once we are sure that the baby will be viable and we are reaching a stage where we can weigh the benefits and risks, we deliver before having to get to the end of the pregnancy. So somewhere around the 32 weeks, sometimes we have to deliver sooner, but around that, and try not to push too much more than that. And then for me, what I do with my patients is I also try the first few days to keep the women monitored in the hospital, and especially in a heart and vascular kind of environment, either the ICU or the intermediate unit. And the goal for that is that, as we said, we know what's the normal physiology. And so, for example, in the first 3 days after delivery, there's a lot of fluid shifting back from the uterus back into the blood. So we know that there is a high risk in the first 3 days. And so some of my protocols have been to maintain close monitoring. Can we prevent it? No, but what we try to do is try to be there immediately if something happens so we can treat it. So unfortunately, we can't yet prevent and that's a lot of the discussion that we have when we talk to our patients about family planning, is that once someone gets pregnant, unfortunately, there is no guarantee that there will not be dissection. And as much as we can plan for it, we can't prevent it. And as much as we can plan for the best outcomes, we can't always control the outcome of dissection. If it happens in a place in the hospital, we might have time, but it's not always a guarantee. So I think that's the scariest part about it, and the riskiest part about it is that unpredictability of it.
Yeah, true. So then what is the, can you just talk about the importance of family planning prior to getting pregnant and knowing your family history? Maybe Melissa?
Yeah.
Can you hear me? Yeah, now I'm off mute. Okay. And just to add to what Rana said, like, I mean, I think, you know, the American Academy of Cardiology, there is ways you can replace and sort of prevent the type A dissections if we know, and the aorta is above a certain threshold with some conditions, but like she said, there's no guarantee. And then those people are potentially at risk to have dissections beyond where you've replaced the aortic root. But talking about family planning and what was the other thing? Sorry, I missed.
So yeah, so that comes with planning. So I think some of the discussion before is if there is an aneurysm, then do we plan to kind of fix it ahead of time? And that's something that I can also talk a little bit more about after. But I think even the discussion, do you plan? What do you do? What are you need to know? I usually also some of the abilities for contraceptives or alternatives, I also go to Melissa and my partners in obstetrics to have their advice. So I would love to hear Melissa.
Yeah, and so family planning really just means, you know, we are not here to tell people whether or not they should have babies. I think our job is to try to see somebody prior to them getting pregnant and sort of talk through the risks and benefits of them carrying a pregnancy. And then also we talk about other alternatives, but I'll tell you, and that brings up, I didn't mention this other research project that we actually have going on right now. If anybody has used surrogacy, please contact me, because there's, we're doing qualitative interviews to sort of get more information about that process. So anyways, you know, the traditional method of having a baby is that you carry the baby yourself. Some people do in vitro fertilization where the sperm and the egg come together in a dish. If they know a gene change, they sort of want to select out for that and not put back an embryo that has that gene change. And then that embryo can actually be put back into the pregnant person or the person that wants to become pregnant, whose, you know, biological child that is. Or alternatively, it can be put into a different person, which is called actually a gestational carrier, if it's not their genetic material. You know, and then the third option for people to, if they want to start a family, is adoption. But the issue is in the community, really sort of what I've heard from people is, number one is it's really expensive, and insurance, depending on where you are in the country, what kind of insurance you have, may not pay for all of this. And this can be like tens and thousands, like tens and $20,000 and $30,000, you know, each time. And then if you want to adopt and you have some type of a chronic medical condition, that sometimes precludes people from actually being able to adopt a child. And so, you know, we present these alternatives to patients, but they're not always available. And so family planning really comes down to, like, you can do whatever you want, but if you know that you have risks in your family, it really behooves you to meet with the high-risk obstetrician, meet with the cardiovascular surgeon, meet with all this team together to hear about your options, hear about your risks, and then each person really makes a decision of, if they want to start a family, how they do that. And then sort of getting to what Rana was saying, like with contraception, we have no data. Let's start there. Is that all of this is dogma, and like we know and think that pregnancy we know is this higher risk time. Why is it a higher risk time? Does it have to do with the hormones? There is thoughts that there were pregnant people that passed away from another reason, and they looked at their aortas after pregnancy just because they had an autopsy and they died for a different reason, and the aorta is changed, and like the actual fibers and everything are changed in just normal pregnant women. And so like there's something going on that pregnancy affects this, and if it's hormone related, getting to sort of a roundabout talking about this, we worry about estrogen and progesterone contraceptives. And so birth control methods, a lot of them have hormones in them, but I'll tell you that, birth control has traditionally been something we tell people in this community to avoid. We don't really have great data for that, and we need to gather more data. But I mean, you need to listen to what your doctors are saying too. Other alternatives are sort of IUDs, which are little implants that can go into the uterus. If you get them taken out, you can have a baby when you're ready. And the ones that even use hormones, it's just locally having a hormone. It's not getting into your bloodstream. It's not going through your whole body. So that's generally thought to be safe as well. And then, progesterone only things, like there's implants that can go into the arm, or there's progesterone birth control pills that can be used. The problem with those is they're really unforgiving. So if you don't take the birth control pill at the same time every single day, there's a high chance you'll ovulate. So then you're still really being fertile. And so it's not saying to people like, we don't want you to have babies. It's sort of hear about all the risks, really plan a pregnancy ahead of time, and then you can go forward. And that's the best way to really have the safest pregnancy. And the last thing I'll say is that, we can't, to sort of add to what was said, we can't prevent dissection, but what we can do is have a whole team ready. And that can be the difference between life and death if you do have some type of a dissection. And you can't save everyone, but just knowing, because there's a lot of overlap between signs in pregnancy and heartburn and different things. And dissection can present different ways. And people are like, oh, you're just pregnant and like have problems from pregnancy. But the more we can get people to think about this and think about this as something that could be going on and diagnose it sooner, that's going to be really helpful.
Yeah, thank you. There's so many times, well, like my case, nobody knew what was going on. Nobody knew what the reason. And the same thing, like, oh, she just had a baby. She's going to have aches and pains. And it kind of was like blown off at first, and then going back to what you said about the options too, like surrogacy, I know that there's a lot of questions around that. And I myself had those questions early on because they said not to do hormonal birth control or even IUD. So then it went to a copper IUD, and until you were ready to do a tubal ligation or whatever your decision was going to be. But I think a lot of times women don't really know how to get this full advice and how to go about getting that advice. And when their doctor is just immediately saying, like mine, for example, they said immediately in the hospital, do not get pregnant again. It'll for sure kill you the next time. And that may very well be true, but at the same time, it's, I understand that they're, not counselors, and it's not all going to be lovey talk to you. They're just being direct because that's their job, right? But at the same time, it's a hard pill to swallow when you're on the receiving end of that and the decision's kind of being taken away from you. And so a lot of times these women are really searching for somebody to help guide them on this journey. Like, can I, should I not? I don't really know all the answers. And so how do they get started? You mentioned about getting a multidisciplinary team going. So like, how does somebody reach out? They just reach out to their OB and then they find a cardiovascular surgeon. I mean, how do they get started? Rana, I don't know if you want to get started, talk about that. Like, how do they get started on that process? Maybe when they know their history, or if something did happen and they already had an event and they want to move forward with a whole team.
So I think, first of all, I mean, I will have to say, like in the last 2-3 years, I've had about at least around 3 to plus women who got pregnant and were sent to the hospital for termination of pregnancy with either chronic dissection or other diseases or aneurysm or Marfan. And when the maternal fetal medicine team here had that, the first thing they did is come and consult us and me and ask us. And then we kind of sat and had a discussion, just like Melissa mentioned. And then we came to the conclusions that the women wanted those precious pregnancies, and that we came up with plan, and all 3 delivered good healthy babies, and they're all well. And some of them required surgeries during pregnancy, and some of them after pregnancy, and others just follow up. So it's a different plan, and again, it's a team, right? And like you said, the key for that is having a plan. I have a plan for the follow up. How do we want it? And then we have a plan for the planned delivery, but we also have a plan for the emergency. Meaning that in case of an emergency, call this person and this is what we're going to do. That's the initiation. So we're not going to start thinking about what we're going to do in case of an emergency. That is the plan. If it happens before this week, this is the plan. If it happens after this week, it's summarized and the entire teams are aware of it. So that way it doesn't depend on one person. And so it's important to understand. I'm not saying that it's easily done. However, it is knowing that there are a few teams in the country that have that, not many. I think it's upon us, and that's part of what we try to do, me, Melissa, and people like us, is try to educate as much as possible, teams as well, physicians. This is a scary situation for the women who get pregnant, but also for the physicians that treat them. It's not an easy thing, and it's something that's scary to treat young patients who you think that by not getting them pregnant, you're preventing it. So you're kind of feeling bad and guilty if you don't say don't get pregnant, right? If you don't say you don't get pregnant, then you're actually encouraging them to, and maybe you're risking them as well. So people who are not always familiar with the guidelines or treating women like that, the majority will probably say that. And don't get me wrong, maybe the discussion after weighing a lot of the risks, many of the women would decide not to get pregnant. The guidelines still do not recommend getting pregnant. But they still give guidelines in case of pregnancy, how to manage it, right? So we're still not telling everyone with the disease, no, it's free for you to get pregnant, because there's a high price. One thing about it, I would say, is look up. Melissa can also give you her information and her contacts for consultations. I can give you at the end the website for, the link for our website and my information. We have high-risk specialists from outside of Houston, others that have referred patients to us. I'm not saying it's the solution. I had a patient who moved from one city to another to be closer to the team during her pregnancy so she can deliver. So there are situations that required, but there are sometimes that we can consult your team. It doesn't necessarily mean you need to come, either me or Melissa. And I know that there's at least another 1 or 2 teams in Houston that do that. In Texas Children, there is a team in Baylor. So there are teams that have specialty. So centers who have high experience with aortic disease usually will be able to guide and help, because they would have that. So the key to it is having a center that has high volume and expertise in complex aortic diseases and aortic dissection, because usually they'll be able to guide. It'll be preferable if they have a specific team that also works together already. But I know, and Melissa knows, that this is rare to have teams fully assembled like that. And have it ahead of time, meaning all of the young women who have those diseases, they already know. So you can do your research ahead. You can have that information out there and somewhere. So in case of something happening, it's easy to approach. It's easy to go to your physician and say, hey, I found this. Do you mind? What do you think? Do you consult? Because a lot of times in the heat of the moment, it's hard for us to look for things, and it's hard for us to already find it. So I usually say preparation is the key. So, and I give you, Carmen, as an example. You're someone who learned and studied about herself and what her options are. And even if it wasn't about just the pregnancy, even about exercise, walking, doing stuff. So you did your homework. You reached out to people. You knew the people. You and I, you were not my patient, and still we were able to meet because of your work. So once I understand that at the beginning, it's a little bit of a shock, overwhelming diagnosis about everything, how you manage it. And then slowly through the community, start asking about physicians and groups, and be prepared and have that available in case you need it, because then you don't have to start looking from scratch. You have those. We're happy to give our contact information, but there are a few others in the country that can definitely be also of help. Melissa, any other suggestions?
I echo everything you said. I mean, I think that everyone can't come see us, but that's part of what the two of us do too, is saying, where are you? Where's the closest place you can go where it's acceptable and like people are going to be able to take care of you and do the things that would need to be done if an emergency happened. But yeah, I don't have anything else to add.
Well, and I want to jump back to also when you were talking about the options and hormones regarding the surrogacy, because I remember asking about, you still have to do injections from my understanding, and my doctors specifically were saying probably not advised to do those, just like it was not advised for me to do birth control pills or any kind of IUD with hormones in it. So the question is does that just vary by patient?
No, well, yeah, I mean, I think it's a great question. And I think, again, it comes all back to hormones, and you have surging hormones. And what they do is they rev up your system. If you're going to do like any type of in vitro fertilization, whether you're putting that pregnancy back into yourself or someone else, and part of that revving up process is it's sort of hormone injections. And now there's other situations where we really try to avoid hormones, and I sort of go back to people that have like breast cancer, right? So it's a similar situation if they've had like a hormonal breast cancer or something like that. And now you can actually, I mean, we don't really know the risks well, right? Because we don't have lots and lots of people yet that have done in vitro fertilization or the egg harvesting stage of things. But you can do something called letrozole, or there's different estrogen receptor blockers that can be given during this whole process, right? And so what that does is you don't get as much hormones as you typically would. And, we've really come far with technology where that's not unheard of. And so the REI doctor or the reproductive endocrinologist that would be doing it, they use this hormone they use an estrogen receptor blocker. And the downside is you will not get as many eggs to harvest as usual. But again, technology has really come a long way, and you can still have a successful embryo made with those estrogen receptor blockers.
Wow, that's all to me, it's just such interesting information. I mean, again, because like you said, I've learned about this stuff for a really long time, and the data that I was given to data that's given out now, it seems to have come a long way in what you can and what you can't.
This is all, remember, this is still, unfortunately, all this is expert. A lot of what we talk about today is expert opinion. Yeah. We don't have the data. We don't know for sure that any of this stuff is safe. We're sort of taking what we do know and think, and then making the best recommendations. And so that was just my caveat.
Yeah, and we do always tell everybody that just to make sure that you do need to still run this by your doctor. I mean, any of these Q&As, whether it's the pregnancy one, exercise, or whatever, that we have these experts come on and talk with us. They do know what they're talking about. However, everybody's case is different, and they don't have your CTs and your case in front of them to thoroughly discuss your case. So like they mentioned, we could always get contact information for them if you wanted to look into that further. So,
and Carmen, another thing that's important, that's what Melissa just said. Not every high risk maternal fetal medicine or someone who will be willing or thinking to do that too. So this knowledge, it might not, so your physicians not knowing is not kind of, oh my God, they're horrible. They're probably the majority of the physicians, right? And if your physician is not comfortable with it, the last thing you want is someone who's not comfortable doing a management like that, because they're planning. So it's okay to understand that and hear that from your physician. Try to see if there's a way to connect. I think most physicians are happy to consult others who have more expertise in certain things. And so they're always willing probably to listen or refer you to someone who's more comfortable with it. But always be cautious and careful, because everything that we're saying, again, we can't emphasize it enough, that it's based on really little data and a lot of extrapolation from other situations and kind of our expertise in dealing with this disease, not only in pregnancy. So we're taking a lot of what we know outside of pregnancy and young women, and kind of trying to see how we can do it. And so it's just important to keep that in mind. That's the difference. And that's probably the importance of everything that we're trying to do when we do research, right? I think because the numbers are so low, we're like asking anyone who can participate in any of those, because that's the only way for us to collect the information and data and kind of go and say. So, for example, the largest numbers that we have about women who get pregnant with aortic disease are in Marfan patients, because that's that kind of like one of the first genes that was very well known on top of other, like compared to other genes that were diagnosed in more recent years. And so just by collecting data from women like that, we know, for example, that women who have aortic root or aortic ascending aortic aneurysm less than 4 centimeters, their risk of dissection is about 1% or less, right? Compared to women who their aneurysm size is larger than 4.5, and that number exponentially increases. And so we are able to use these numbers and we're able to guide our patients because many of the patients that were studied or looked at, their outcomes were women who were Marfan, right? And so that's why it's important right now for us when we're asking for participation in those studies, is because that allows us to collect more data and have a little bit more understanding and kind of back up to what we're assuming or thinking. And maybe there would be things that we were saying that we can't do, and actually we can, and the numbers would prove us wrong. Or there would be things that we would think that they're safe and turns out to be that they're not, just based on the data that we get. So it's really important to get that information and that data.
Yeah, well, thank you so much for saying that too, because I know I'm a huge proponent of research and trying to get people involved in doing that, because in really any kind of area of aortic disease, because without us participating in these things, we're never going to really fully learn from these cases, you know, and the potential to help the future affected is so great, I think. So I really appreciate you guys' efforts and your projects and what you're doing with those. I had a question that I didn't really think about until somebody asked me one day, and they said, what would just even lead a normal pregnant woman to ask for an echo or a diagnostic that could be like indicative of them having an aneurysm or a dissection? Like what would diagnose them when there is no family history, or what would have them go ask to get checked? That would be out of the realm of your normal pregnancy.
Well, that's the tricky part. I think without family history or any symptoms, that's really difficult to justify it. And again, sometimes I'm also someone who's very cautious about overdoing tests. Sometimes when we overdo tests, we also kind of like have the false positives. Like there are a lot of things that suddenly start causing us to worry, and all of us are starting to chase things that don't exist. So for anyone who has a family history or have anything, that's for sure. Anyone who has symptoms for dissection, I think, Carmen, you can also say you can't miss it. Like most of the cases when they're especially young patients, acute dissection, it's a sharp pain that you can't really miss. It's not that you're going to be pregnant and have a dissection, not know that you have it. So I don't think that there are, so the signs for dissection are usually going to be the sharp chest pain or back pain that's out of the blue, things that are, that's out of proportion to anything that you've known before. And so that's some of the typical. Now, on the other side, of course, the heartburns and other things that come with it, with pregnancy and the discomfort. Sometimes that's where kind of some of the physicians might kind of like, discard and say, no, there is nothing there. But any symptoms that are shortness of breath, I would say, that discomfort and pain in the chest or the upper back, those are things that should prompt some kind of workup for it. That doesn't mean any woman who's pregnant who has those is going to have a dissection or an aneurysm, but definitely those are things that we take seriously, and echo is not an invasive study. But if you don't have those symptoms, it's very difficult to guess or predict or find out. I think a lot of them are going to be incidental, and I don't know that there are other things. I think, Melissa, is there anyone who doesn't have any of those symptoms that come to you for normal pregnancy that you would send them for an echo just because?
I mean, we do. So there's like the echo looking for the aortic size is not something you're going to be routinely doing. I mean, we get echoes all the time, and I think it's sort of saying similar things to you, like, you know, listening to your body is the main thing. And there's a lot of different aches and pains in pregnancy, and shortness of breath can happen. Pains can come and go when you're pregnant, and like the reflux can be really severe. But if something just doesn't feel right, and you go to the doctor and they're like, you're fine, you're just pregnant. I think the biggest thing is, in sort of echoing what Carmen's story was, is like she knew something was wrong and she kept trying to advocate for herself. And I mean, we do echoes now. I mean, echoes are done more routinely, like for shortness of breath, or if we think someone's getting into heart failure, but they should be doing aortic root measurements on all of the echoes. I think it's just the quality of who's doing those measurements. But if there was a big aneurysm, somebody should be picking that up, right? I mean, but I think the scariest part of all of this is what we talked about in the beginning, is that, like, it's sort of this silent thing until it's dissected, right? And so, like, that preventative or prophylactic trying to find something before it happens is really, really hard, because aneurysms are not really symptomatic unless you had imaging. Get that imaging, you have to have symptoms usually, if there was not family history or something else. I don't know. I mean, I think family history is
is important.
I know that that's not always the case for people, but I think that can be something that really makes people look at you really differently if they all of a sudden hear somebody died early in the family. And it may not be that people can use the word aortic dissection, but for me, like, I try to teach people, if there's some type of sudden death of a family member that's cardiac in the 40s or 50s, like, you first need to see that that's not a heart attack. But if it's not, or they talk about any vessels rupturing, that's where I get more worried that maybe they just didn't have the right words to talk about aneurysm or dissection.
But another thing for everyone is if we're talking about family members years ago, and they did that, also sudden death or calling it heart attack, sometimes they just call it, because that's the one thing that people can think of. And so again, family history is important. It's important to also know the numbers and data, right? 60% of the women who would dissect, around 60% of the women who would dissect, will end up having some kind of genetic mutation that we will find out. Meaning that maybe there is some family history or hints that were there that were just not spoken about or talked about or understood. So even by just focusing and understanding your family history, we kind of might also kind of recognize at least some of those that were missed until dissection. That still leaves those 40% that their genetic testing still turns out to be negative. And so that can be that there is really no known mutation, or it's something that we just haven't yet found or understood. But
so should they just when should they get genetic testing? Like, so say somebody comes to you and they have an aneurysm, and then they also know they're pregnant now. Like, can you or should you go forward with genetic testing right then, or is the monitoring and the multidisciplinary team kind of enough in that moment?
Genetic team is part of the multidisciplinary team. So genetic testing is part of it, because the decision making depends on it. So the latest guidelines for the American Heart Association and the ACC were just published in 2022. And some of the updates on it also is that different type of genetic mutations, we have different threshold for interventions and guidelines. And the reason for that is that there are, and I think Melissa can talk a little bit more about it, is that not all Loeys-Dietz are the same, not all Marfan's are the same. And so different mutations behave differently. And we already know that some are more aggressive than others. And so in certain mutations that we know about, we also know that, you know what, I need to fix this aorta at a smaller size before getting pregnant versus someone who we say if it's 45. And so the meaning of what is your genetic mutation is important and becoming more and more important in the decision making of that multidisciplinary team. So if it is someone who we find out that there's an aneurysm and that person hasn't been diagnosed, genetic testing for me is a must. Melissa?
And I'll add to that I think any kind of aneurysm or dissection in pregnancy should be sent to a geneticist, because that's not normal. It's never normal for that to happen. And I think the other thing too is, unfortunately, I've seen cases of, like, we had someone die from a dissection, pass away from like a type of aneurysm, and you can do genetic testing once somebody has passed, and we can't necessarily help that person, but that could be life-changing for the rest of the family members. And so it's important also on autopsy for people to think about genetic testing, which I know is sort of a morbid topic and not something we want to be thinking about. But if there was somebody who did pass away in pregnancy and it was found to be a dissection, genetic testing can still be done.
Yeah, that's a good point. And really, in any case, I mean, there's cases where, you know, it's a younger, like a teenager that it happens to, and it's important for the rest of the family to know the answers for that. Okay, so I'm going to dive into some more of these questions. We've got about 20 minutes till, so I'm going to kind of dive in, and just whichever one wants to answer a little bit, you know, just kind of pick what you want to answer. So one question was, what is the guidance for a woman who has a mechanical valve on warfarin on becoming pregnant, knowing that she has a high risk?
You want me to take that one?
Yeah, go ahead, Melissa. And I'll add.
So, yeah. So once somebody has had mechanical valve in itself, it's sort of one of the highest risk things you can do. It's one of the highest risk pregnancies out there. And the main reason is because we're weighing, if that valve, so when you're pregnant, going back to just physiology again, it's your body is trying to be smart. So when you're pregnant, your blood is actually thicker and you have a higher chance of clotting. The reasons for that are because you bleed after a delivery. And so we want you not to bleed to death. So that was sort of Darwinian, that, like, you know, it's sort of something that we've adapted to that your blood is thicker while you're pregnant, higher risk to get blood clots. And so with that mechanical valve, the biggest thing we worry about is with that higher clotting state, you could clot off the valve, which could be life-threatening to mom. And so that's number one. And so we have different ways that we can sort of thin the blood while you're pregnant. We'll talk about, so there's warfarin, which is a pill, or Coumadin, and then there's injectable things such as heparin and Lovenox. And then there's the newer forms of anticoagulants that can be pills or injections. We don't have as much data with that newer stuff. Warfarin works really well for people with mechanical valves. The problem is that crosses the placenta, and then the baby will also see the warfarin. And so there's actually a syndrome that can happen from babies that have warfarin, that they can have different features of their face, and it can sort of cause a syndrome if you're on that early in pregnancy. And then later in pregnancy, right when you're getting towards delivery, if somebody's on warfarin, we worry that that baby also has thin blood, and then I hate to say the word trauma, but like just the action of either passing a baby vaginally or through a C-section could cause bleeding in the baby's brain. So we do sometimes put people on, or keep people with mechanical valves on warfarin, weighing the benefits and the risks of that. The alternative of the injectables, so Lovenox and heparin, are very safe in pregnancy. They don't cross the placenta, so we don't have those risks, but they don't work as well. And there's the chance that that valve for the mom could clot off. So it's sort of this risk benefit. There's not necessarily a right answer for each patient. Just like all the other stuff we've been talking about, we sort of handle that on a case-by-case basis. And then people with their doctors make the best decision for them and what they want to do, and, you know, weighing the risks and the benefits.
So some of the things that I would add to it is that in the recent years, so if someone had the valve surgery in recent years, sometimes when people use the word mechanical valve, those are type of new valves that actually can tolerate lower levels of anticoagulation and lower levels of warfarin, but then it has to be a specific type. So that's kind of like that's why you need to know what you have. Your physician needs to know what you have. Your cardiac surgeon will be involved in that. And so in certain types of valves, that would be. Now, maybe what I would add here is one of the most important things is that if a young woman is having those surgery that, you know, ahead of time, right? She's in the childbearing age, someone who has not done with the family planning, and you're now having a discussion with your cardiac surgeon to fix your aorta and the valve with it. That's where sometimes a lot of the time the discussions happen about whether they put a mechanical valve or whether they use a tissue valve for those discussions, even though that in younger people, we usually recommend the mechanical because of durability. It lasts a lot longer than a tissue valve, but sometimes in those situations, we do, then the decision goes towards putting a tissue valve just to allow that young woman to get pregnant. So it's important to know these things, to have those discussions ahead of time, just because as you saw and heard from us, it's very complicated managing it once it's there. But it's still doable, and I think surgeries that happen in recent years, the type of valve might be different that allows for it. So it's important just to know that.
Okay. And then this is kind of, how long after a diagnosis or repair can one discuss family planning? I mean, is there a time frame, or they can just kind of, if they're wanting to do it, just talk to somebody right then, or is there a certain time frame that they need to wait?
So first of all, talking to someone about it is not bad to talk about it immediately, even though someone who's going to be still overwhelmed by recovering from surgery. And I find it the only reason is for maybe, even if it's just to hold your horses, kind of like, let's not jump, maybe just having the conversation early on might kind of say, hey, we know it, we hear it, let's let you recover and we'll talk about it. Just so people, because I've seen also patients who said they wouldn't, and they talked about it, and they wanted to come, and then a year or so passes by, and then suddenly they come when they're pregnant, but yet we didn't get a chance to work on the plan that we needed to work on. So having a conversation, I don't think that there's any time that it's too soon. Having said that, getting pregnant, of course, there's times that we're going to recommend to recover well from surgery. You want to make sure that your wounds are healing. It takes a few months to actually for your body to get back. So I wouldn't recommend for anyone who's having an open heart surgery to think about pregnancy with any time less than 6 months from after surgery. I would give that at least that kind of amount of time. First of all, to see that you're recovering well, that you're getting back to your health, that your bones have healed well, that the inflammation around surgery is past and gone. And then to look at your other aortic, I'm pretty sure the remainder of the aorta, that it's stable, right? And so that kind of like is, again, that's the most crucial part of it. So I wouldn't consider it in any time less than 6 months, but even 6 months might not be enough. Having said that, mentioning it and talking about it is important, just so you keep it and your physician keeps it on your radar.
Okay.
And just to add to that too, I think people sometimes, I've heard this with congenital heart disease, but also with aortic, that people say don't get pregnant, and then people interpret that as my body cannot get pregnant, not that I shouldn't get pregnant, and then they think that they don't need birth control because they are infertile. So it's always important to clarify if somebody says things like that, like what do they mean? Because it doesn't make you less, sometimes, like it depends on, of course, what's happened during your surgery or whatever, but it doesn't necessarily affect your fertility. So you're still fertile potentially. It's just that we're recommending you wait to have the baby.
Gotcha. One woman asked, is it possible to have the abdominal or descending aorta repaired prior to pregnancy when an aneurysm is present? And maybe that's the question along the lines of, like, they really want to have a baby and they currently have, maybe it's something that's small or large, like, are they still going to be able to do it after?
So it all depends on what we're fixing, right? First of all, just remember, even when we fix one part, if the rest of the aorta is not all completely replaced, then you're still at risks in the other parts of the aorta. And so you weigh the benefits and risks, right? So if the aneurysm in a certain segment of the aorta, and even in the descending, is not big enough for an indication to repair, big surgeries to repair in young people has its own risks. Risk for paralysis, risk for kidney failure, for bleeding, all of these things. It's a major surgery, pain and recovery from opening the chest and your belly if need to. So it's not a small surgery to be fixed, right? And so, and especially if we're going through this to fix a small aneurysm in a very specific area, then we're leaving the rest of it not repaired, right? And so I wouldn't be someone who say, I fixed it, you can get pregnant, because then I will go to have the same discussion that the remainder of that, you still have a risk at the rest of the aorta, right? And so it doesn't completely eliminate it. Having said that, if there is a segment in the aorta that reaches that level of 4.5, between 4 to 4.5, especially in the ascending, and it's bigger a little bit in the descending, depending on the genetics, and there is a plan to get pregnant, there is room to have that discussion and repair it for sure. Like I said, it eliminates the risk of dissection in that segment. It doesn't eliminate it in the rest of it, but it's definitely something that's worth the discussion. Doesn't necessarily immediately mean yes repair, because it depends on each case, but it's worth the discussion.
One woman asked, how does a mother's diagnosis affect the child's health, and what should one do? I think she was concerned, like, would her child have a heart condition? So I guess just kind of, that's kind of reiterating the importance of genetic testing from the mother, I guess.
So maybe Melissa, you want to explain what it means genetic and does it pass on?
Sure, yeah. So a lot of these conditions that we talk about, if you have a change in a gene, everybody has like 2 copies of their DNA. Usually you get one from mom, one from dad, and usually just one copy has a change. And I sort of think about it, if you have a book, right? So you have a book and there's lots of genetic changes that we can have. You can have things where like a whole sentence is missing or a chapter's missing. You can have things where like the word cat is missing a T, like a deletion. But the things we're talking about here are usually misspellings in a gene. And so it's like a book that has misspelling. So there's a word that's misspelled somewhere. With that, it's usually just one copy, but this is something that's a dominant condition. And so that means that you have a 50-50 chance, if you have one of these genetic changes, to pass it on each time you have a child. And each time is actually a separate event, meaning it's a coin flip every time. So if your first baby is okay and your second baby is okay, that doesn't mean your third would be okay as well. It's sort of a 50-50 chance every time you do get pregnant.
And I would add, kids had it, once you have it, it doesn't mean like, oh, I already have them, probably the third can't have it. It's the same risk all over again. So it's just keep that in mind.
Yeah. And so a lot of these are autosomal dominant conditions, meaning there's a 50-50 chance for each person, like every time they have a pregnancy, if the mom, or we talk about the, biological dad is the one that's affected. So I think that's the answer to that one. I mean, there's ways to do genetic testing. That wasn't really necessarily the question, but you can do testing of an embryo if you did that in vitro fertilization. And then there's 2 time points in pregnancy where you can do testing on the actual pregnancy in the first trimester with something called chorionic villus sampling, and we sample the placenta. Or in the second trimester, usually we do something called amniocentesis. Both of those have a risk of loss of the pregnancy just from the procedure. The chorionic villus sampling, or it's called CVS, is a 1 in 300 risk versus the amniocentesis is a 1 in 1,000 risk that you could lose the pregnancy. And then some people decide, I do want my child to have testing, but I don't want to do anything that's going to put that pregnancy at risk. And then you could just do testing once the child is here as well.
Now, the other aspect of the question, I wasn't sure if the question was just about genetics, but let's say someone got pregnant and a dissection happened during the pregnancy. What's the effect of that on the fetus, on the baby during the pregnancy? So it depends on when it happens. If it happens early on, first of all, type A dissection, meaning a dissection, a tear that happens in the part that's closer to the heart, that has a risk on the mom's life. So first of all, that puts a mom at risk. And About 60 to 70% of people might die if they don't get operated on within the first 24 to 3 days. So it's an emergency if that happens. Now, what does that mean? It means that the blood flow is not going well to a lot of organs. It's tearing, it might be bleeding. If the mom is not getting that blood, then the baby's not getting the blood. So it also puts the baby's life at risk. Now, let's say this happens in early stages of pregnancy, where if you deliver right now, then the baby, the fetus, cannot survive outside of the uterus. So that means that you go and do first the surgery to fix the aorta. Putting a patient on heart and lung machine in order to fix it, those things by themselves have a risk of losing the pregnancy. It can cause up to 30, sometimes 40% chances of losing that if we do it early on, but sometimes we don't have a choice. So we just go and do the aortic surgery while the baby's still in the uterus, hoping that it won't risk, but that's a higher risk. If it happens after a certain week, and usually we look at it at around 28 weeks, I think, and Melissa, correct me if you look at it different, but I think 28, even though it is still very early, but at least if that happens around that time, and that's how we put our plans, then we start with a C-section delivery, and usually that probably is going to be a baby that's going to go to the ICU and be premature with all the problems that come with that, and only then go to the heart surgery immediately and fix the heart and save the mom, right? And sometimes if the mom is at an immediate risk, then we don't even think about it. We just go to save the mom. And so the situation itself of an acute complication of an aneurysm during pregnancy has also implications on the pregnancy and on the baby, not only the genetic aspect of it.
Okay. Yeah, definitely a case by case. Is everybody's different. What advice is there for diagnosis 12 weeks along? A patient is 12 weeks, has sought the genetics clinic due to family history, and they advise an echo. Baby aspirin was given due to her previous pregnancy having preeclampsia. Is there anything else she should be doing?
So is it someone who has an aneurysm? Sorry, I missed.
I believe she does, and that's why they sought the genetics clinic. Like, she was sent to a genetics clinic due to her family. Actually, it might just be because of the family history, because they advised an echo. So maybe she doesn't know yet, but is there anything else? So I guess that kind of takes us back to like the multidisciplinary planning.
Approach, one of the things that I would start doing is, first of all, getting an echo. That's the simplest, easiest things, and to look at aorta and see the size of it. If there is a strong family history, because the genetic testing can take a few weeks. If there is a strong genetic history and there is pregnancy, I can easily just go and send the woman to do an MRI of the chest, abdomen, and pelvis, because that can give me and show me if there is an aneurysm that we're missing, and it's still safe for pregnancy. Even though in emergencies, if we need to, we can still do CT angio, but I also easily can do an MRI here just to get the size. If we don't see any aneurysms, then I wouldn't change much other than wait for the results for the genetic testing and go from there, because if they're negative, then continue normal follow-up. If they're positive, then you're going to just repeat the imaging and build up the planning with that multidisciplinary team to have that usually every at least quarter. And sometimes if there are something that I'm more concerned about, I can do repeat imaging within every 4 to 6 weeks or 8 weeks, kind of like build it depending on each case. And so if I find an aneurysm, then the discussion would be around what size is it, where it is, all of that. And so if there is a very strong family history, I wouldn't think a lot about getting an MRI and just having a baseline and making sure that there isn't a missed aneurysm.
Yeah, I would just add also, like, if we do find something or think, and then they do have the same gene change, like even if they seem lower risk based on their like aortic size, I would put them on a beta blocker, because that that medication is really safe. Out of all the beta blockers, if you're in the United States, we usually will put people on metoprolol. The reason we do that is because some beta blockers have been associated with a higher risk for the baby getting small, or growth restriction, or being small after they deliver. Atenolol is sort of one of the bigger culprits of that, which people are usually on sometimes prior. But a beta blocker, even if you have low blood pressure, we think that what it's doing when you go back to the physiological changes of pregnancy is it's decreasing the shearing forces on the aorta. And so I try to, even if somebody has a low blood pressure, put them on a baby dose. Like, we don't know what the right dose is. If you talk to cardiologists, they'll give you their parameters of their, what heart rate you're going for, or what blood pressure you're going for. For me, I think there's maybe, just going back to like mouse models and everything, I think that there's potentially just something that beta blocker is doing to decrease the shearing forces. And so I just try to get people on a little bit of a dose if they can tolerate it.
And one of the questions, and we've talked about this before, Melissa, was about breastfeeding. So a lot of times people are wanting to do so after they have had a dissection, or they have an aneurysm. They don't know what's going to happen. Are they okay to do so after they deliver? And can you just kind of give a little bit of general guidance on what the experts say?
I think it depends on what expert you talk to, and I want to be respectful of everyone. That we don't, so in humans, we don't have the answers. Like, we've heard that theme. There's pretty convincing mouse data. If you have a severe, like, Marfan mouse, and now they've done the same thing with vascular EDS to make a mouse model. And what they found is that when the mice go to have babies, right, they have multiple babies usually, but if you took the pups away, that in itself would sort of rescue them from the dissection phenotype. And what they convincingly show is that the hormone oxytocin in a mouse is related. So oxytocin, we all have that in our pituitary, in part of our brain. And basically it gets stimulated to make your uterus contract when you're in labor, and then after you have the baby. And then it also helps with milk letdown when you're breastfeeding or chest feeding or however you're doing it. And so they convincingly showed that if you strongly block the oxytocin receptor in mice, that this prevents dissection. Okay. And so that's where all this comes from, is that, are humans the same as mice? And the fact is that this hormone is also released. It's sort of a promiscuous hormone. So it's released when we bond with our infants. It's released when it's a love hormone. And so, yeah, you could potentially say don't breastfeed based on this mouse data, but I will tell you, at least going back to what Rana talked about, that like a lot of our data is from Marfan syndrome, right? And so when I was in fellowship, we did a project looking mostly at people with Marfan syndrome and Loeys-Dietz, and 70% of people in that cohort breastfed. Okay. A tiny percent of people had dissections in pregnancy. And if you compare, you can't really significantly say, like, the ones in the postpartum period, yes, there was higher percentage of women or pregnant people that breastfed. Okay. But a lot of people breastfed who do not have issues. And so I think that there's more to learn, and it's more complex than we realize. And so I sort of talk to people about the mouse data and like advise it. And some people I think really truly believe in this and are advising people, the way to avoid as much risk as possible is do not breastfeed or breast pump for your child. My stance is more that I say to them, here's the data that we know in mice. I think that your team needs to be aware that postpartum is a high risk time for you to have a dissection. And, maybe we're putting ourselves at a little bit of a higher risk if we breastfeed. We don't know. And so if you have any symptoms, and reviewing again all the symptoms of what a dissection can look like, and making sure everybody knows to be sort of on high alert, and maybe doing more serial imaging to make everybody feel better. But we don't know that the cause and effect is breastfeeding causes dissection necessarily.
Okay, thank you. And then just kind of after the fact. So with your newborn, a lot of times these women we're preoccupied with, can I lift my newborn? I mean, there's cases that have gone through endovascular care. Then you have those who have done the open heart surgery. So they might have a different kind of pains and such that they can't lift. But as far as the weight goes, I mean, I guess that's more the question. Some are very fearful. They might just be on the floor, like they don't want to lift them at all, or they're told not to lift more than, 10 pounds, and their baby's already that much, at a month old, or even as a newborn, I guess some kids. So they're really scared to move forward, and they feel like they can't really do the bonding and do things and be playful with their child. So what advice do you have for them?
I think this comes again with what we always say, kind of learn and know your body, right? And so we're also trying to work more into the exercise aspect of it and understand what we can do with dissection. This comes part of it, right? Carrying a baby is just like carrying, weights. I don't tell them anymore, don't carry 10 pounds or 15 pounds. I try to say, try to kind of limit it to quarter of your body weight, but more than anything, it's anything that you're going to lift it and feel like you're straining. That's when you know that you shouldn't, right? And so probably in the early times, in the early kind of months or weeks, it's easier, especially if you don't have an open heart surgery to do that. But there are sometimes ways where you can adapt, right? Like try to figure out ways where you don't have to carry them straight from the floor or from something that's very low. Try to kind of level your beds in a way where they're higher up so your effort is not as high. So kind of like, it doesn't necessarily mean completely don't, but be aware of it. If you have an open heart surgery, it might not be comfortable and easy because you're in pain, right? And so it doesn't mean you can't bond, but maybe someone can bring the baby to you while you're sitting and you're carrying the baby instead of having to go and pick up the baby. So there are definitely adjustments that need to be made. It doesn't necessarily mean absolutely not. So it's just a matter of knowing and understanding. And I think big aspect of this as well is the anxiety and the fear itself. What if, what would happen if I'm with the baby and this happens? What would happen if something happens and I have my baby in my arms? Do I drop them? Do I fall? Like there's a lot of aspect to it that it's not necessarily just the carrying and the weight. It's also the mental aspect of it, which is something that's also crucial. And I think we need to, and I've heard a lot from my patients, and I think we're also, one of the things that we're looking into or working into see how we can incorporate that is how do we care for the mental health and give the support around that anxiety things, and what does it mean that you bond, but not necessarily the way you had in mind that bonding needs to be, or what does it mean? So I really think the way I look at it when I talk to my patients is just think about it that we want your baby to have a mom while they're growing up, right? And so we want to do precautions and things that our recommendation is how do you adjust your life a little bit, but still maintain that quality of life with the baby, because even without pregnancy, any one of us who has major surgery or major disease will have to adjust a little bit, right? We would all have to adjust about when do we go back to work? Do I carry heavy stuff? Am I able to do the things I need to do, right? And so adjustments we do all the time, and it's not just in pregnancy. So it's not that different, but then we still need to find our way where we can do things, but not necessarily eliminate it. So no one says you can't carry your baby, but then think about how do you do it without adding more effort and kind of like with a little bit of thought about it.
Thank you. And I know we're running past what we had planned, but Josh, do we have any live questions at all in there?
Well, I posted an anonymous question link, and nobody's used that just yet. Let me refresh that to be sure. And Bruce Waldrop dropped in to say, hey, everybody. Hey, Bruce, he's one of our Aortic Hope ambassadors.
Oh, okay. Thank you. So, well, I can ask a couple other questions if you guys are okay to go a little long, just because there was some other questions that I had on just hormones after the fact, because I know it's not just the family planning and the having the baby and the things just right after, but even a lot of us who've had this happen and are the kids are growing up and then we're moving on to this next stage. And then we talked about hormones for birth control pill, but what about later in life? So I didn't know what the guidance was on hormone therapy after an aortic patient, approaches menopause. Are they advised to do so or not?
Let's take this one.
So disclaimer is I don't do a lot of gynecology anymore, but I've pulled in friends that do more menopause work and, just things that happen with your periods. But talking about menopause, so when people go through menopause, they have lots of changes in their body, and they can cause symptoms that really affect your quality of life. And I think this is all expert opinion, so the disclaimer is there that depending on, it's important to talk to your gynecologist and talk about hormonal, and then there's also now a lot of non-hormonal options to sort of deal with things like hot flashes, or sort of figure out what exactly your symptoms are, and then what's sort of the best type of thing to do with that, like in terms of what kind of treatments are available and alternatives. And because there are some hormonal things, but some of the hormones are just local, like in the vagina, or versus taking pills. I think it's sort of the same thing, is that we worry from this dogma thing where hormones the culprit in the first place that makes pregnancy a high risk time. And so it's sort of sitting down with your doctors, sitting down with, like your gynecologist may not know the answers for all of this, but making them sort of have some type of phone call or some communication with the surgeons that have taken care of you, like the genetics people, the cardiologists, and everybody decide like what is safe and not safe for the person to do in terms of helping them with symptoms.
Okay. What about recommendations on a hysterectomy post-aortic care?
So I think that goes to the discussion of what are plans for family planning. For example, if the person decides that they don't want to take the risk at all, and that's the solution, I think that's one of the options to consider. But I also will leave maybe Melissa to explain about what are the risks in doing that, or what are the implications of doing a hysterectomy at a younger age if you don't have to.
And I guess the question too is, when people say they're trying to move forward with hysterectomy, is that for family planning, like for birth control, or that they have other reasons to have the uterus removed?
I think it would just be for, I'm not sure exactly, but just later on, I don't think there's a reason for just going straight into it, but just, is there any kind of contraindication because you have an aortic issue?
Well, every time you have surgery, right? I think it depends on where your dissection was. I would say if you had abdominal aortic surgery, I don't know, Rana could probably speak more to this, but like if there's scar tissue or anything that then can make the surgery of getting the uterus out a little bit harder. Since I did gynecology, we've really changed, and the uterus is usually removed now laparoscopically or robotically, which is a minimally invasive way to take out the uterus, and people have their uterus removed after they're done childbearing for lots of different reasons. I think the main thing with that is usually if they're just removing the uterus, they leave the ovaries there so that you don't go into menopause early. But I wouldn't, the one thing is I would say, like, if you just had the baby, we do not usually take out the uterus then, because you have twice the amount of blood pumping through the uterus and everything. And so we don't really want to do that surgery unless we had a reason right when you're pregnant. But later on, I want to have Rana also speak to this, because I think like if you have a reason to have your uterus removed, like people remove it for pain, for fibroids, for bleeding, sometimes pre-cancer.
There shouldn't be a contraindication as far as the aortic dissection itself to remove it. I think Some of the things that need to be taken into consideration in vascular EDS, for example, and other things, the tissue are friable, so the risks of surgeries need to be weighed in. So it's not necessarily the fact that you have a dissection somewhere is going to complicate your hysterectomy. And again, as far as family planning, just like Melissa mentioned, I think that's kind of like the extreme aspect of it, but I rarely think that people do that. However, there isn't a reason not to do it because of an aortic dissection. Even when we do the repair, there's rarely a repair only in the aspects of the belly, and the uterus is in the pelvis, so it's also kind of far away from most of what we do. So it shouldn't be complicated by what we do. Having said that, again, it's a case-by-case discussion because there are certain genetic diseases that the tissue that is friable is not just the blood vessels. So kind of like you take that into consideration.
Do you, like, if somebody had their aorta repaired, Rana, and then they're going to have laparoscopy where they're, you know, sometimes we think about like if there's getting their belly filled up, then that's maybe putting more pressure on the chest. Do you worry about that at all? Like if they were going to have like a laparoscopic cholecystectomy or like getting their gallbladder removed or something?
No, it shouldn't be, especially if we're doing surgery, because it's never about the pressure in the chest that changes it. And if let's say we're doing what we call thoracoabdominal, meaning that we've repaired the chest and abdomen together, we kind of go in a different incision and we go from a different layer. And now we're getting into technicalities that you guys don't understand, but I know it's hard to kind of understand that, but our body is built in layers. So I can actually go to the back of the book and not touch the front of the book, right? And so sometimes the surgery is being done in a certain direction that the scarring that we caused is not necessarily going to influence if you go and do surgery and now you have to open the book from the other side. Kind of like as if you glue the last 2-3 pages, but not the first 2 pages. Something similar to that, kind of just to understand the concept. So sometimes understanding your history is what's going to guide us. So it's very difficult to just give a generic answer to it. It's probably a case by case, but I do not have in mind a specific reason not to do it just because you had an aortic dissection. I actually have also been in C-sections and deliveries with patients who've had aneurysms or dissections in the aorta and looked at it after the delivery to make sure nothing is there, and it doesn't necessarily, it's most of the times it's in different planes, so it shouldn't cause an issue.
Okay. Thank you. Because, yeah, I know we have some women that are just kind of all over in that group that, you know, there's a lot of questions ranging from the beginning stages to the end stages. And so there's always those questions about hormones and whatnot too. Well, we do have a few other questions, but I don't want to hold you guys too long. We could always try to do another session sometime soon to finish up some more questions that people have. But I think for the most part, we got through the general questions of like advice on getting pregnant and the things that people are really concerned about early on in the family planning period as well. So is there anything else that you guys can think of that we?
No, one thing that I can say is if you have questions and you know that they've been sent by specific women, I think you can let Melissa and me know. We're happy even to answer them, like either in writing or whatever, even just to make sure that the women who asked that question get the answers, at least for this, and not wait for it. So we're happy to do that as well. And we're happy to have another session in a couple of months or something like that if there are more questions or if people feel that they need to. At least I know I am, and I'm speaking in Melissa's name, but I know we just feel
she
like
volunteers me for stuff all the time. No, I'm just kidding.
Well, I appreciate you guys' time so much, and yeah, we'll do that. So what I'll do is get these questions with you guys, and maybe we can just post the answers within underneath this and like the comments of this video. So thank you again so much for your time. I appreciate you guys so much, and the community of women that you're helping appreciate you very much as well.
Happy to be here.
Happy to be here, and thank you, Carmen, for you and to a lot of women. Like, you've created a community, and I think I always use you as an example for someone who kind of took control over her life and disease and helps others a lot. And so I think you're always inspiration also for us and helps us and pushes us to do and kind of enjoy what we do even more. So we thank you as well.
Yeah.
All right. Thank you, guys. All right. Well, everybody, we will try to get these two back on again another time. And so we appreciate you tuning in. Good night.
Okay. Bye.